Hello everyone, my name is Adiba Kamarulzama and I'm the current president of the International AIDS Society. Welcome to the IAS Educational Fund event. The IAS Educational Fund brings the latest and best in HIV science, including science presented at IAS conferences, to key stakeholders and implementers targeted at capacity development opportunities. In doing so, we hope to catalyze action through strong collaborations at community, country, regional and global levels to better engage in the HIV response. As we all know, with the COVID-19 pandemic over the last 2 years, it has had a tremendous impact on HIV response in all our countries around the world. The last 2 decades of the HIV epidemic has seen tremendous progress in HIV treatment and prevention science, with many tools developed to help us achieve our goal of ending AIDS by 2030. By bringing the best in HIV science through lectures from international leaders in HIV, as well as conducting workshops through these events, the IAS hopes that we can help you reinvigorate and re-engage the HIV response in your respective countries. Please enjoy, and we wish you all the best.
Thank you, Adiba. My name is Prosper Okonkwo. I'm the Chief Executive Officer for APIM Public Health Initiative, and it's truly my pleasure to welcome you to this symposium. I'm sure we're quite aware that in the last 2 years, the COVID pandemic has stressed and threatened many of the health systems in our developing world. And HIV response has also kind of lost quite some of the gains that it made from the beginning. And this morning, I would like to start by thanking the members of the Program Planning Committee, Dr. J. Samuel, Dr. Plank Dwale, Dr. Olabanjo Ogunshola, and Dr. Temi Omole from APIM, as well as Professor William Ampofo, Morenike Okwong, Professor Francois Mbopi Keo, Karim Dio, Asmao Gwatenkojo, and Michael Kombo. Thank you all for helping us put together a great program for the symposium. It is also my pleasure to be moderating this session, which will be focusing on HIV and COVID-19, West Africa and Central African success story. As a way of introduction for the symposium, this first session will focus on the HIV situation in light of the pandemic. All countries responded differently during COVID-19, and participants will hear about examples of best practices and opportunities for the HIV response brought through the pandemic. Representatives from different countries will present what successful strategies have been put in place to continue to maintain the successful response. I'm therefore very much looking forward to the many interesting presentations from our great lineup of speakers. After their presentation, the speakers will participate in a Q&A session, which I will also be moderating. During this session, the audience will have the opportunity to ask questions to our panelists by submitting your questions through the chat box. We sincerely hope that this programming will be of value to all of us for our current work, and that the key recommendations and discussions will help catalyze actions, strengthen capacity, and to continue engaging in the HIV response, support for you to continue improving strategies, policies, and practices at the community, national, or regional levels. Before starting, however, I'd like to share some housekeeping rules with you. All participants are currently muted. Please note that interpretation in French is made available for those of you connected online. Please select your language at the bottom of your screen to hear the presentations and discussions in your preferred language. I invite all those connected virtually to please introduce yourselves by typing into the chat interactive box that is right underneath the screen. And you will see that your message shows in the interaction box to the right of the screen. Please type your first name, your last name, the organization you work for, and the country you are from. Let us use this unique opportunity to connect and get to know one another. If you are having technical issues and are unable to see the chat box, I would like to invite you to change internet browser and to select all cookies to be able to interact with the speakers when entering into the platform. Please use the same chat box during the question and answer time that will take place right after the presentations. You are all welcome to send comments in the chat box. At this stage, I would like to pass on to Segi Eholie to talk about IAS work and a special membership offer for you. Segi, thank you.
Dear colleagues, friends, I'm Professor Serge Paul Eholie, member of the Governing Council of AS, and on behalf of the AS, welcome in this symposium. This is a very important topic regarding the two pandemics, HIV and COVID-19. Most of us have forgot HIV during the latest 2 years, but the disease is still there, and we are still challenging with HIV. We know that there's a real link between HIV and COVID-19. We have a higher risk of COVID-19 and higher mortality in HIV, in people living with HIV. And we feel and we face also of the impact of COVID-19 on National AIDS Control Program. And we knew that due to lockdown, some of the people living with HIV, treated patients, did not get their drugs or were lost to follow-up or unfortunately died. But we saw also that the national HIV, and we faced also the reduction of the funds allocated to HIV. And that was at the beginning. But hopefully, the donors as PEPFAR Global Fund and the voice of some civil societies and AS also pushed to increase the funds allocated to COVID-19 without decrease the funds allocated to HIV. And most of us responded to the call of the Global Fund for COVID-19 and HIV. We were ready because before COVID-19, we were pushing for the differentiated model of care, and that was very helpful for us because we helped our patients during lockdown to have drugs for 3 months or 6 months. We have new tools to increase adherence, to increase follow-ups. So we mitigated the impact of COVID-19 on HIV. So far, we are pretty sure that the HIV system, the HIV knowledge, skills, and the HIV adaptation after Ebola and now COVID-19 is a resilient system based on public-private, civil society partnership. This is very wonderful. And I want to acknowledge all of us for this. So we need to share the best practices on this response, this adaptation of HIV people working on HIV program to this COVID-19 pandemic. But don't forget that people living with HIV are still vulnerable, and we need to prioritize this population for vaccination. Before we start, I would like to thank Hiv Healthcare for the support for this virtual meeting, for making it possible, and the support of all the memberships of AIDS. According to this important meeting and this important discussion that we have today, and we're sharing these best practices, the International AIDS Society is also pleased to present a special offer regarding its membership. As an active participant of the AIDS Educational Fund, South Asia Symposium, you are eligible for this offer. If you buy a 1-year membership, you will get an additional 6 months added to your membership for free. If you buy a 2-year membership, you will get an additional year added to your membership for free. Please contact memberships @aissociety.org as indicated on the slide. I fully support and fully suggest that you try to be member of this AIS team, this AIS network in the wide world. I wish you a very, very fruitful meeting, and again, thanks for your participation.
Thank you. I am now pleased to introduce our first speaker for this session, Patrick Brennan, who is the Regional Director for the support team of the West and Central African region at UNAIDS. Patrick Brennan has more than 30 years of experience in development and HIV. He began his international development career as a rural development volunteer with the Peace Corps, and later the United States Agency for International Development. Mr. Brennan rejoined UNAIDS in September 2004 as the UNAIDS country coordinator for Thailand, where he served for 5 years. Subsequently served for 4 years as the UNAIDS country coordinator in Malawi, and for 1 year as the UNAIDS country director in the United Republic of Tanzania, before becoming the UNAIDS Deputy Chief of Staff in 2014, serving in that role until March 2018. Mr. Brennan will be speaking to us this morning on HIV in West and Central Africa, a regional overview of the recent successes. Mr. Brennan, the floor is yours and you have 10 minutes.
Thanks to the moderator, thanks to IAS and to APIN as well for the invitation to be with you this morning. Patrick Brennan, the UNAIDS Regional Director for West and Central Africa. And I've been asked to just very briefly touch on an overview of some of our recent experiences, successes in the region with respect to HIV, which I will do reasonably succinctly. And then for those of you who have questions or would like some additional information, you can please feel free to ask subsequently in the question and answer section. With that, let's get started. Next slide, please. So very briefly, as you can see over time, West and Central Africa has progressed. And so we are trying to change a bit the dynamic and the discourse in particular about the region, away from a region left behind or a region seriously lagging behind. Our advances aren't as quick or as much as we would have liked, but we also like to think of ourselves as a region in transformation, specifically because, as you can see, though we haven't achieved the 90 target in 2020, we did have close to 40% reduction in new infections, so we are making progress, albeit slowly. There are still 200,000 new infections in the region, and most particularly, and I won't dwell on this further in the successes because it's not yet a success, but in particular, the number of vertical transmission cases, the number of children being infected with HIV is unexceptionally high, and is exceptionally high and is actually unacceptable in our region. And that is due in no small part also to the fact that almost half of all pregnant women in the region who are living with HIV also do not have access to ART. And so what more needs to be done, and in particular for the colleagues in Nigeria as one specific country, will be important. But I won't dwell further on the challenges and the issues. I'll try and focus on the successes as I've been asked to do this morning. The next slide, please. And so I will try and break these down very succinctly, and they don't cover by any means the depth and breadth and variety of all of the things that have happened in the region, and many of the successes that those of you who work on the ground have been also very critical to. But I'll touch on just some of them as headlines. On the policy side, one of the most important things, and again, I presume many of you have been involved in this, is the fact that we have successfully over time now rolled out differentiated access to services in more than 90% of the countries. And that includes both PrEP and self-testing in a number of countries of our region. That has been critically important to ensure that we are, especially in the COVID time, nevertheless able to get services to the people in a way that they need them, in a way that they can benefit from them, whether it be multi-month dispensing, whether it be various other approaches, in particular with community partners, which I'll touch on a little bit later. But the differentiated access to services, I think, is one of the critical reasons for the successes that we've been having in the region. A second policy success is the last November, our Dakar High-Level Summit, which was convened by Macky Sall, who is both the president of Senegal and currently the president of the chair of the African Union. And we hope that with the results and the recommendations from the High-Level Summit, we will indeed be able to keep HIV clearly on both the programmatic as well as the political agenda in the region moving forward. Programmatically, we have seen progress in our HIV treatment and care cascade. We aren't at the 95, 95, 95 where we'd like to be, but 77, 73, 59 is a decent result in terms of the 2020 data. We're looking forward to the new data coming out shortly, which hopefully will show even more increases. And it's important to point out that these increases and this improvement has happened over time despite COVID. I mean, in the region, we've seen a growth in access to care and treatment and improvement in the cascade by roughly 20% between 2018 and 2020. And just as one example, Nigeria, as one country, was able to increase their cascade successes by almost 30% between 2019 and 2020, despite COVID. And so progress is possible even in the COVID era, and we hope that now with COVID, by the grace of God, lessening in the region, we will see further successes. Another very important programmatic development has also been the strengthening of national information systems, because as you know, one of the biggest challenges in our region is having accurate and accessible data to make decisions, to make policies, and to implement our programs. We now have 18 countries in the region which have estimates at the decentralized level, so they have much more granular understanding of their epidemics, and thus their programs and their priorities can also be much more granular in response to the reality of the epidemic that countries face. We hope to roll more of this out into the additional countries of the region during the course of the coming year. But that has also been a critical success in ensuring that we have the fundamental underpinning of making the kinds of decisions and implementing the kinds of programs that we need. The next slide, please. This is just a graphic visual representation of ART coverage across the region. And as you see, though it's by no means ideal, it's also by no means nothing. We have had successes, coverage is increasing. There are challenges in certain areas of certain countries, but nevertheless, we see the coverage increasing. The next slide, please. The two more areas that I will talk about in terms of our successes are the areas of financing and partnerships. Now, in terms of financing, we have been very successful, and apologies to the English speakers for the Fonds Mondial, FM, as opposed to GF for Global Fund. But we have been very successful in mobilizing Global Fund resources over the last few years in our region. The last funding cycle actually saw an increase by $750 million with a B billion in the WCA region. And that has also been matched by investments with the the various COVID financing mechanisms of the Global Fund. So we have actually been very successful in mobilizing additional external resources. PEPFAR as well has been a very important partner. We have $500 million with a B in dollars from the PEPFAR investments in our region. And not only in the focused PEPFAR countries, but as many of you will know, we also have a regional program of PEPFAR that now covers 8 countries of the region. And those are important catalytic investments as well, often not nearly the level of the Global Fund, but nevertheless good supplemental funding for national responses, in particular focusing on some very key areas in the countries where they're working. We continue to do advocacy for enhanced domestic financing of the response, and I'll show a slide after this which shows that there has been some success in that. At least we aren't losing as much ground as we feared we might with COVID. And the biggest challenge now, as many of you well know, is going to be how we continue to encourage our governments to create the fiscal space that we need for investment in various elements of the supporting social sector programming that we need, whether that be social protection, whether that be health, whether that be education, in order to begin addressing many of the vulnerabilities that drive HIV in our region. And one area of success as far as financing is concerned is the abolition of user fees. We've got a very good example in Cameroon, and thanks to the colleagues in Cameroon who have worked on this. And we hope to use that as advocacy across the region for the further elimination of user fees across the boards to ensure that people, especially in the very difficult times that we find ourselves in economically across the region, that the most economically challenged citizens and members of our communities are not also obliged to actually pay out of pocket for their healthcare, but rather that we can abolish user fees as much as we possibly can. So that has also been an area where we think we've made some success and are quite pleased. The final area that I'll talk about is partnership, and there, as many of you well know, we have over the past couple of years worked to rejuvenate our collaboration with and programming together with civil society organizations. The Civil Society Institute for AIDS and Health in West and Central Africa has been established. They cover now 21 countries with 149 members. If any of you are members of organizations that aren't yet a member, please write to the Institute here in Dakar. They're more than happy to add anyone and everyone to their membership. And that's becoming a very important device in terms of both the credibility and the voice of civil society, but also civil society to civil society collaboration and support in order to strengthen our civil society, regional networks, our national networks, and local partner organizations. A second partnership area that's been very important for us is continued support to and revitalization of the various networks of people living with HIV and AIDS across our region, and including in particular the networks of women living with HIV. This being very important to us to ensure that indeed we have the appropriate voices at the table to ensure that the interests of the communities most affected by HIV continue to both be heard and to be served by the programming that we are putting together. And a final very important area, I think, where we've been collaborating with ITPC and with USAID are issues of community-based observatories. In other words, helping and empowering civil society organizations to really be programmatic, not just financial, but programmatic watchdogs for their national responses in their respective countries and communities. It's been a very successful exercise. It's also been very important, again, in building that linkage between government and civil society, where civil society is not just seen as a recipient, but they're an active partner and player in the process. And that has also been critical to many of the successes that we've seen. The next slide, please. I won't dwell on this, just very briefly underlines the fact that we are still very short of our ideal level of funding and investment of resources. But I would highlight the important fact that, as you can see here, up to now, and we suspect new numbers coming out in June or July of this year will reflect this, we haven't seen great increases in domestic funding, but we also haven't seen significant cuts in domestic funding. And I think given all of the challenges that we have faced in this region, that continues to be an area that is extremely important. And we need to ensure that the advocacy is being done with national partners, with governments, with ministries of finance to maintain and or increase the fiscal space as and where they can for the kinds of investments that we need. The next slide, please. This is my final slide, and I will again be very brief in terms of summarizing a few critical points from the lessons of the HIV response, what COVID can learn from them, and how in many ways COVID and HIV have effectively worked together to continue to have success as far as HIV is concerned. The first one, and this goes back to the last point I was making on communities, placing affected communities at the center of our response and at the center of everything we do, whether the governance, planning, service delivery, monitoring, accountability. Communities and community partners need to be adequately resourced, effective partners in this process if we are going to go that last mile, if we are going to reach the most vulnerable, the most marginalized members of our communities, because it is with and through community and civil society organizations that we will be able to do it. Without their involvement, we will not be able to achieve the results that we want. Second critical point, and that again relates to both HIV as well as COVID-19, is ensuring that our response is firmly grounded both in an understanding of human rights and of equality, so that we are paying very much attention to the kind of enabling or unfortunately often disenabling environment that we see in our countries. We need to work to further remove punitive and arbitrary discriminatory laws, policies, which unfortunately increase marginalization rather than decreasing it, and more importantly, undermine access to the essential prevention and treatment services that people need. If we are creating barriers rather than removing them, we will not be able to achieve our results. And practice has shown across the world that when these barriers are removed, when laws and policies are changed, we actually do see significant increases in the results that we obtain. So it's again something that to be encouraged, not just for HIV, for COVID, for many other areas as well. The final area and final lesson that I'll talk about is again to be effective response for COVID, for HIV, as it has been, needs to be necessarily multi-sectoral. Everyone needs to be at the table and involved. And in particular, it needs to be multi-sectoral because of the variety of social and structural challenges, risks, inequalities that exist across our communities, across our nations, which increase people's vulnerability to infection, again, be it HIV, be it COVID, but also impede service uptake and service access. If we aren't ensuring that people have access to the quality services that we're trying to make available, then we still won't achieve our results. And so it's not enough to just ensure we have good quality services. People need to be able to access and use them. And so again, a critical lesson is ensuring that there is both the disappearance of barriers to that service access and mobilizing people to understand that services are there, that they can access them, and encourage them to do so. And with that, I will conclude my presentation. I hope that it's been a quick enough overview and insightful enough for some of you. And I will return the floor to the moderator. Back to you, Mark.
Thank you very much, Mr. Brennan, for this very comprehensive presentation. Now it's my pleasure to introduce our second speaker, Mary Boyd. Mary Boyd is the country director for the Centers for Disease Control and Prevention in Nigeria. In her role, Dr. Boyd leads one of CDC's most prominent country offices and coordinates CDC's collective efforts in global HIV and TB, global health security, malaria elimination and immunization. And since October 2020, she has served as senior advisor for HIV and TB prevention for this CDC Nigeria as a regional and international expert on HIV and TB prevention. Dr. Boyd will be speaking to us this morning on the best practices from Nigeria, opportunities for HIV programs brought during the pandemic. Dr. Boyd, the floor is yours. 8 minutes.
Good morning. Good morning, everyone. I'm Dr. Mary Boyd, the country director at the U.S. Centers for Disease Control and Prevention in Nigeria, and I am thrilled to participate in Session 1, HIV and COVID-19 West and Central African Success Stories. Today, I'll be sharing best practices from Nigeria, opportunities for HIV programs brought during the pandemic. Nigeria has an estimated 200+ million population size. This is the largest in the continent and one that's fairly young, with nearly half of the population being under 15 years old. In 2004, Nigeria had an estimated 7 million people living with HIV and an HIV prevalence of 3.9% among adults. In 2003-2004, PEPFAR came along, targeted 15 countries with 3 distinct goals towards tackling the HIV epidemic. And this really was a game changer in Nigeria. The first 12 years of PEPFAR in Nigeria was characterized by rapid acceleration in the number of people with access to ART. And this increased more than 100-fold. This went on until 2016, when we sort of reached this plateau. And while examining the program strategies during this time, it was clear that to some extent, we really were flying blind without current data. We had provided access at this point to the most accessible population with little data, and we no longer knew where the remaining people living with HIV were, how many they were, who they were, and therefore it was difficult to program. In 2018, that all changed. The Nigeria AIDS HIV Indicator and Impact Survey, or NICE, gave us valuable information that then dictated our strategy. We actually found out we had a much lower prevalence than initially thought. And we, in fact, did not have 7 million people living with HIV, but 1.76 million. We knew now that the prevalence in females was double that in males. And we were surprised to see what was a concentrated epidemic in the South states and the Southeastern states. Now that we knew where people living with HIV were and their demographics, epidemic control was in sight. But we needed to drastically change our approach in order to achieve epidemic control. So we set out to design an antiretroviral or ART surge campaign with the goal of increasing the number of people on treatment by 500,000 in a year and a half, something that we'd never done before in the history of Nigeria's HIV response. We kicked off the surge in 2019 and almost immediately saw quick results. Steady increases in the numbers of people that were now accessing ART. And then COVID-19 hit. Yet despite COVID-19, you'll see that we continue to put more people on treatment. In fact, we saw that during the COVID-19 pandemic, we progressively increased the number of people we brought into care quarter after quarter. And finally, Nigeria saw the largest growth in its treatment cohort of any PEPFAR-supported country during the pandemic. So essentially, while it was a challenging period, through PEPFAR, double the number of people in Nigeria now have access to life-saving antiretrovirals, and this happened in the last 2 years. Also, countless lives were saved from the devastating effects of COVID-19 due to now access to testing, treatment, and vaccination, thanks to the use of this robust and resilient HIV response system. So what was our strategy? When we looked across all our PEPFAR-supported programs in other high-burden countries, we knew that there were certain tried and true or best practices. We recognized that the best HIV responses across the globe were adaptable, that they gave room for autonomy and creative thinking, but had accountability in place, that they made timely decisions with accurate data interpretation, that they shared knowledge and challenges openly in an iterative manner, and that they were connected. Of particular challenge in countries with high burden in some of the more rural or harder to reach areas. So what we did was set out to apply these principles, which we called CIRES, Comprehensive, Integrated, Resilient ART System Principles, in our HIV response. So number one, adaptability. First, we needed to adapt our program to reach people and no longer wait for them to come to us. So the once primarily facility-based program needed to quickly change to become an active community outreach case-finding program. Moreover, with COVID-19, people were no longer coming out to facilities due to lockdowns or movement restrictions, so our responders had to receive these special permits from the government to go out during that period. And with proper infection prevention control training and working with civil society and community-based organizations, they became part of the government and community's foot soldiers, responding both to COVID-19 and HIV. It was then that we saw a rapid increase in the number of cases we were identifying. And not only this, but we were now finding cases much earlier in the HIV course, as opposed to later, which is what we used to see when we waited for them to come to facilities. These are some examples of that experience, which included advocacy to community leaders and expansion to hard to reach communities. And number two, we also created an enabling environment that fostered autonomy to identify critical issues, to design solutions or actions, and also provided accountability for results through supportive supervision and technical assistance. And demonstrated here in this is the impact of that cycle of technical assistance visits, which, as you can see, resulted in continuous quality improvements. In particular, in this case, through this technical assistance, was able to increase the number of cases that were, the number of tests that were being conducted, and subsequently cases as well. We created a dashboard that populated site-level progress, daily focused on key indicators like case finding or treatment. And then we came together daily and weekly to discuss and act on them. We formed an incident command system, appointed an incident commander and operation chiefs for each state. And this structure was ideal for Nigeria's HIV response because of all the stakeholders that needed to be involved in achieving the goal. Before COVID, we started utilizing video conferencing technology and relied much more on that during the course of the pandemic. We even extended this formation to our COVID-19 response. As early as March 2020, the US CDC's Nigeria team organized the mission in an incident command system to include other agencies. And this became the primary vehicle for responding to the pandemic within the US Embassy Nigeria. So where are we now? There have been 4 COVID-19 waves, and the future about variants remains uncertain. Vaccination campaigns continue to ramp up with support from the HIV response sector and other sectors as well. And the integration of service delivery has been identified as a critical part of the security of health in this country. So in summary, we can say Nigeria's progress in scaling up ART reached a plateau in 2016, but the NICE population survey unlocked key information for strategic planning. The Cyrus strategy became a catalyst for the surge, and COVID-19 was an opportunity to then adapt the response, but also to demonstrate resilience of that approach. And lastly, I'll say that sustaining HIV epidemic control through a resilient response is indeed key to weathering future COVID-19 waves or other pandemics. Thank you.
Thank you very much, Dr. Mary Boyd, for this very interesting presentation. I'm sure there'll be a lot of discussion at the Q&A time. It is now my pleasure to introduce our third speaker, Stephen Aisi Ado. Stephen is a public health specialist and program manager of the National AIDS STI Control Program in Ghana. He is a member of the International AIDS Society and the World Conference on Lunch Health, an academic mentor and part-time lecturer at the School of Public Health, University of Ghana, Legon, and Ensign Public Health School and the College of Physicians and Surgeons. He's also a member of the Program Committee of the Ghana AIDS Commission, the National Expert Committee on Schistosomiasis and Soil Helminthes, and the National TB Advisory Board. Dr. Stephen will be speaking to us this morning on best practices from Ghana, opportunities for HIV programming brought during the COVID pandemic. Dr. Stephen, the floor is yours. 8 minutes, please.
Good day, colleagues. My name is Stephen Aisi Ado, the program manager for the National AIDS and STI Control Program in Ghana. I present to you the opportunities for HIV programming brought during the COVID-19 pandemic in Ghana. In summary, I'll touch on the background, HIV epidemic in Ghana, the effects of the pandemic on our program, opportunities for programming, and acknowledgement. As at the end of December 2020, the estimated population of people living with HIV was 346,120. 7% of that were children. Our 1990 trajectory was as follows: 63, 95, and 73. We estimated about 19,000 new infections and 13,000 deaths in that year. Ladies and gentlemen, our prevalence was 1.7% for the adults, and among ANC clients, 2%, among female sex workers, 4.6%, and men who have sex with men, 18%. Mother-to-child transmission rate was 11% at 6 weeks and 21% at 18 months. HIV among STI clients was 10%. Since the onset of COVID-19 in Ghana in March 2020, we have experienced 4 waves to date. And each of the waves was associated with a disruption in HIV services from testing to treatment and retention in care. And so you can see that at the beginning of each wave, there's a decline, disruption, and then there's a gradual recovery. You see that in the numbers that were tested positive as well in this slide. And then the next is the numbers initiated on treatment. So from March, you see a disruption, and then there is a recovery, and it continues sinusoidally. But there were opportunities. With COVID-19 came COVID-19 funds to support services, and so personal protective equipment, infection prevention control implements were provided through the Global Fund to support services. Resources was also provided for differentiated service delivery strategic initiative. Through the UNICEF, there was resources for stigma reduction and to support mental mothers who support pregnant women on treatment. WHO provided additional funding for differentiated service delivery strategic initiative. All these funds made it possible for us to be able to improve service coverage also in 64 additional differentiated service delivery sites, which we developed a DSD scale-up plan and strengthened a community cadre initiatives, the mentor mothers, the community adolescent treatment supporters, case managers, and models of hope. These are persons living with HIV who supported one another during the pandemic with all the implements to be able to enhance access to services. To also bring services closer to our clients, we had to deal with the issue of stigma. So stigma reduction programs were undertaken, and we embarked on certain community delivery services with the support of these community cadres. These are things we are looking at expanding also. Multi-moms dispensing was a priority through the delivery of clear guidelines to ensure that our persons living with HIV had enough commodities for 6 months and more to minimize their movement to the health facility. There was improved quality service through index testing scale-up, and we noticed a very high yield of more than about 20% positivity in index testing and family-based index testing. Quality improvement interventions for differentiated service delivery, and also for virtual solutions, training of service providers using virtual platforms. We are looking at taking advantage of further virtual platforms for distribution of HIV self-test kits. And we've started a pilot already. We introduced the viral load report automation system, where samples are taken and then shipped to testing sites, and the results are also brought through electronic means, unlike the past where it was all manual. We took advantage to introduce point of care for viral load in some districts, and we're scaling that up. We intend to continue to use virtual platform for supportive supervision and subnational engagement, because that proved to be very complementary to the limited in-person contact. For data decision making, we are deploying an MAE system for PrEP and HIV self-testing and capacity building for DSD cascade analysis. We also strengthen community-led monitoring and the introduction of scorecards as a feedback mechanism to be able to improve the data for decision making as far as our HIV program is concerned. All the things that we were able to achieve and continue to focus on were possible with the leadership of the Ministry of Health and the Director General of the Ghana Health Service. And we are so grateful. We're grateful to the Global Fund to Fight AIDS, TB, and Malaria for their continuous funding, technical support, the WHO and UN system, our principal recipients, other principal recipients, and other partners, and implementing organizations within the national response. Thank you.
Thank you very much, Dr. Stephen Ado, for this very insightful presentation. I now move on to the fourth speaker, and it's my pleasure to introduce Michael Julius Enongene. Julius is a fellow IAS Research for Cure Academy, a public health clinician and HIV medicine enthusiast. He has over 5 years of experience of initiative and innovative primary healthcare, working within Cameroon Baptist Convention Health Services. Between 2019 and 2022, he has served with the HIV-Free Project arm of CBCHS as HIV clinical advisor, site project lead involved in team leadership, system strengthening, managing HIV, AIDS care and treatment services, PMTCT, pediatrics HIV programs, providing technical direction and oversight for project implementation and monitoring in fragile settings. His main interests are in innovation of HIV cure and education, and access to this care for all, especially the Global South. Julius will be presenting on the topic, best practices from Cameroon, opportunities for HIV programs brought during the pandemic. Macaulay, the floor is yours, 8 minutes.
Okay, to begin with, I'm extremely thankful to the organizers for calling me up to participate on this platform to share best practices from Cameroon with regards to opportunities, HIV programs during a pandemic. I'm Macaulay Enongene Julius, public health clinician and HIV medicine enthusiast, a fellow IAS Research for Cure Academy. I'm currently a postgrad student, HIV/AIDS management at the Stellenbosch University. I currently work as the HIV/TB clinical advisor and site project lead for Cameroon Baptist Convention Health Services, an implementing partner for PEPFAR. PEPFAR funded the project for HIV activities in Cameroon. So that said, we know that almost 40 million people are living with HIV worldwide, and about 74% of these persons are having access to ART. And we know that amongst these 37.7 patients living with HIV worldwide, there are about 68% of them who live in sub-Saharan Africa. And for our region of concern, there are 4.7 million people living with HIV and 3.5 million having access to ART as of 2020. In Cameroon, where there's a population of about 25 million, over 530,000 people are living with HIV, and about 57% are receiving ART as at June 2019. And it's worth noting that the HIV burden in Cameroon is regressing. Since 2004, where it stood at 5.5%, it's now at 2.7% as at 2018. And the COVID-19 situation in Cameroon, we presently have about 62 active cases, and about 1.5 million people are vaccinated. It's no news that prior to the emergence of COVID-19, HIV and AIDS constituted the biggest global pandemic. And quite frankly, there has been some progress in combat towards HIV and AIDS. We know that AIDS-related death has dropped by up to 61% since 2004, and the new infections have dropped by 52% since 1997. But we also know that HIV, we also know that COVID-19, just like any other pandemic, has not been the only thing which has caused some breakdown in the speed towards the combat to HIV and AIDS. We had the other pandemics, we had other disasters, and we see that in Guinea, 2004, 2005, where despite some of these pandemics and disasters, we are having some adaptive measures in the form of differentiated service delivery, where in Guinea, 6 months ART refills were being dished out. Similar situations in Sierra Leone, where community dispensations was one of the models adopted. In a country like Central African Republic, where there was the conflict in 2015, we see that there was 6 months refill distributed by lay healthcare workers to peripheral health facilities. Similar situations in Mozambique, where there was notably armed conflict. Community dispensations was an aspect which was capitalized on. And in Cameroon, where I presently work with the ongoing socio-political crisis since 2008, what we are doing is we are having to give out 6 months ART where stock permits, because as we will see, COVID itself has impacted on the stock tensions. So where stock permits, we are having to provide 6 months 6 months dispensation, and also go about community dispensation activities. Talking about the impacts of the pandemic on the HIV delivery in Cameroon, we saw a regression of healthcare seeking behavior among the patients living with HIV, not just the patients living with HIV, patients as a whole, as they fear catching COVID. And so with that, they stay away from the facilities. And we begin to note patients who are lost to follow-up, interrupting their treatment, and so on. We also know that some staff picked up the COVID and have to stay at home, quarantine, and this alone caused a drop in the workforce. These two factors contributed in a decline in new cases, a decline in case identification, a decline in initiations secondary to COVID. And one other aspect which constituted an impact was as a result of misinformed patients. There is that blame on the healthcare providers, healthcare workers being seen as perpetrators of COVID-19 propaganda. Suspension of adult ART support groups was one of the impacts as well. There's also suspension of face-to-face trainings, disruption in supply chain due to COVID. That was being well reported. We also saw significant reduction in external funding, as fundings were now diverted to combat of COVID. And in one study, there were projections that as a result of the potential increase in annual, as a result of the COVID-19, there's a potential increase in annual HIV infections by 21%, and increase in HIV-related death by 9% due to 6 months cessation of ART, alongside 50% reduction in viral suppression among ART users for a 6 month. And this particularly is attributed to ART discontinuations among key populations. In that same study, one of the projections were that as a result of disruptions in condom access, this may translate to 50% reduction in condom use across all partnerships, and this potentially can lead to about 23% more infections overall and 36% more infections among key populations. So these are some of the impacts of the COVID. So talking about practices in Cameroon, when this COVID started, there had to be integration of prevention messaging, not just to train healthcare workers, but to facilitate the field workers in order to better inform the healthcare providers about the new pandemic. Also, there had to be adoption of digital solutions to provide virtual meetings. We also had to provide protective materials, including masks, PPEs for healthcare workers, and also for our clients who made it to the facility. One of the other things that we did as a practice was to bring about the shift system in order to decongest healthcare workers to reduce the risk of transmission. As part of the models, we had to adapt our HIV testing and immunization, where we had to have staff go into the community, carry out community-based testing, verification and immunization, since the clients were far-reaching. We also had to capitalize on HIV self-testing. We also carried out the remote follow-up of our patients to phone calls in order to see that they are doing well from their homes. In order to increase the out facility community options, we adopted community dispensation. We reinforced use of community ART groups, community-based organizations. I also reinforced the family model of ART dispensation, carried out free COVID testing for suspected cases. He also extended the ART's prescriptions, which normally we will prescribe 1 month for new cases and maybe 3 months for the older cases. But this time we had to pull our prescriptions to up to 3 to 6 months, depending on the stock availability. One of the things that we also did was to space out the appointment visits. Now, what are some of the outcomes of these practices? We saw continuous flow of healthcare delivery without any of the interruption, even when the crisis had to drop a little. We also gradually adopted use of online platforms, which was very much in use at the peak of the COVID. And of course, we're still practicing the same thing now as part of our method of monitoring, of evaluating our work. Also, the strict implementation and safety measures that were put in place during the pandemic raised awareness amongst the healthcare workers, even amongst the clients, which are still being adopted today, and it's a positive practice. Things like family model dispensation, which we capitalized on during the peak of the crisis, we are still practicing them now. And it also helps with the continuity of care for these patients. So, thank you very much. I think that is what we had to share from Cameroon on our best practices. And we are open to questions. Thank you once again. There's a few references from
Thank you, Mikolie, for the very interesting presentation. It's now my pleasure to introduce the last, but by no means the least speaker for this session, Idris Asongo. Idrissa is the founder and executive director of the network of HIV positives in Sierra Leone. He's a founding member and current executive director of the network of HIV positives in Sierra Leone, with over 20 years experience in development work. He's a diligent and passionate human rights advocate, especially for people living with or affected by HIV, including the key population. He has served as board member in different organizations and is a member of different technical working groups in Sierra Leone. Idrissa will be presenting on best practices from Sierra Leone, opportunities for HIV programs brought during the pandemic. Idrissa, the floor is yours for 8 minutes. Thank you.
Yeah, I am Idris Asongo from Sierra Leone. I'll be presenting on behalf of the country. And our HIV prevalence is estimated at 1.7% among adults aged 15 to 49 years. This is according to DHS 2019. For the COVID, we registered our first case on the 31st December 2020. And we thought we did pretty well in containing the infection, purely because we already had experience responding to Ebola in 2014 to 2016. And also we had some experience responding to HIV. So we used both experiences to respond to COVID. Now, when COVID started, these are some of the things that we consider to be best practices in our country. We are able to quickly develop a strategy for HIV implementation in the context of COVID-19. And this was done collaboratively with other partners. And once that exercise was completed, we also, as a country, developed a comprehensive HIV, TB, COVID-19 service delivery protocol, and this was also rolled out across the country. And in that protocol, HIV testing and management was actually included as an essential component to respond to COVID-19 case management. Because of that, we had representatives from the National AIDS Control Program that were members of key pillars in the COVID response. For instance, the treatment pillar and also the psychosocial pillar. In our quest to improve access to ART, we officially introduced multi-month scripting of ART. This means that we enrolled all those who were on treatment and those who were newly diagnosed, and they were provided with 3 months of drugs. We also, as a country, activated a point of contact for ART refills and share the numbers of these contacts to people. We are also able to strengthen ART home deliveries for those who actually needed it. As we are responding to COVID-19, we make sure that infection and prevention controls of COVID were actually integrated in all what we do. During counseling sessions, people were screened for COVID as they access facilities, and also IPC materials and supplies were provided to all clinics and offices. This was actually done so that we can contain the virus. Because HIV testing and management was part of the COVID case management, all healthcare workers were trained on HIV testing and management. And this was done for all of those that were actually working at the treatment centers and at community care centers. We also provided ART during lockdowns. How did we do this? We brought partners together, NACP, NAS, NETIF, UNAIDS, and other partners, so that during lockdown we have passes, so that during lockdowns we can move across the country at different locations and share numbers. We had numbers that we can go there comfortably and provide them with ARVs. We are also able to strengthen our virtual meetings. We are meeting on a weekly basis to provide updates on progress, challenges, and profile recommendations. Since we had people specifically from the National AIDS Control Programs that were working at key pillars of COVID response pillars, they were also providing feedback to us, especially those that has to do with HIV, because HIV testing and treatments were done at the treatment centers. So they were also providing feedback to us. We also, as NETI specifically, we were able to train, establish, and operationalize community ART groups. These were groups of people who were on treatment and who were considered to be stable. So they were doing very well. And so we brought them into groups within their communities so that they can discuss treatment issues, they can discuss about COVID-19, and also they can take drugs for their colleagues in turns. We also promoted vaccination among recipients of care and key populations. We specifically engaged an Italian organization known as Lombardi Initiative for COVID-19 Vaccination. We had discussion with them. So we were able to mobilize recipients of care and members of key populations and bring them to specific locations in our offices, in our support group offices, and drop-in centers. And so the vaccination team can come, came there and actually provided vaccine for them. Among our challenges were when COVID struck, community outreach activities like HIV testing also were suspended. During lockdowns, there were restrictions of movements, and this actually affected service uptake at facilities. The air and land borders were closed. And so this actually affected supply chain that actually led to stockouts of ARVs, test kits, reagents, and the rest of it. Of course, there were intermittent breakdowns of equipment. We continue to have stigma and discrimination, and this is really very serious. And among others, challenges were socioeconomic barriers to service uptake because of the restrictions. Majority of the members' income capacity was now low, so that affected service uptake. We continue to have challenges with integration. We've done some amount of integration as a country, but still, HIV still stands as a vertical program. And so we really want to see how HIV services can be fully integrated into the core HIV, core health services in the country. Of course, there is a shrinking space for expert clients, and this has actually affected retention of recipients of care on ART. So we really want to see how recipients of care can be used as expert clients so that they can serve as motivation for their colleagues. Of course, there continue to be high staff attritions, and this is also affecting service uptake. Thank you very much for your attention.
Thank you very much, Idrissa, and thank you very much, all of our speakers. I'm sure you'll agree with me that this has been a time well spent. We're running out of time, but we have a few questions that had been sent to the box, and I think we'll start to ask a few of those questions. Some of them are specific to speakers, while others are just general, expecting that any of the presenters could respond to. The first will be to the speaker from Cameroon, and the question is, can you elaborate a little bit more on the family model that you described? How does it work? So that will be the first question. Julius, over to you, please, very briefly. The family model. Yeah. Okay.
Yes. Hello. Am I audible?
Yes, please. Go ahead.
Thank you very much for the question. In our cohorts, we have couples on treatment. We have family members on treatment. We have them come to the facility to pick up their medications, but in order to restrict that regular movement, we have one partner picking up medication for the other partner, or one partner picking up medication for their children in case partners on treatment or alongside their children who are receiving care as well. So that was one way in which we used, because at that time we actually didn't just suspend the adult clinics for children to so they were suspended. So that's one model which we used, and it helped us reach out on the patients during this trying moments. I don't know if I answered your question.
Yeah, that's fine. I'm sure if there are any more concerns, it probably will get back to the chat box. Thank you very much. This next question, I will expect that any of our speakers could help us. The question is, does any country have concerns about the late presenters, as a result of the COVID? During COVID period, some HIV patients had to present late. Were there any specific strategies that we used to address these late presentations? This is an open question. If anybody can share experience on that.
Okay, thank you. This is Stephen. COVID-19 prevented some people from coming, and so we noticed some loss to follow up and increased loss to follow up within our program. But we had a program, an initiative, this pilot in the Western region, where the models of hope and some of the case managers deliberately, with the contact list of these people, went out to get in touch with them to be able to bring them back to care. And we saw the difference after the COVID, after the impact, when it waned. We noticed, and there were concerns. People were not comfortable. Some people were afraid that if they came, they would have COVID and all that. And one of the other impact was that, the criteria for injecting people with vaccination, initial underlying conditions. And so when that message went out, the people who were living with HIV had concerns, because they were not, for them to get vaccinated, they have to
Yeah, Stephen, it looks like your bandwidth is low and the network is not coming on well.
the HIV, and there was a great discomfort. So we actually had to engage the expanded program of immunization to be able to waive that clause.
Okay, it looks like they did lose Stephen. Mary, can you go on and then maybe once
is it better now?
Okay, better.
Is it better now?
Yes, better, but just
so I think
the right place. Yeah.
The concluding part, I said that for vaccination, we needed to talk to the EPI program to waive that condition, particularly vaccinate people, underlying conditions, and the people living with HIV were in this category, and that created some concern. So that we had to talk to the EPI to waive that so that they can have access to the care.
Thank you very
much.
Thank you very much. Mary, can you come in?
Yes, so Dr. Prosper, thanks for the opportunity to respond. So I was reflecting actually, as I was putting this presentation together, I was reflecting on the fact that as we closed the treatment gap in the program, we were actually starting to see that the number of cases that we identified in the facility was reducing. I think that's something that already happened regardless of the COVID pandemic. But what the pandemic forced us to do was accelerate our thinking and action and strategy around pivoting our program to accommodate that reality. So of course, the fact is that if we're no longer seeing people coming to the facility because those are the people that are well, right? This is pre-pandemic, because those people are well, then already I think with the treatment coverage getting higher and higher, we were bound to find people presenting later and later and later. So in a way, I actually think that, especially, at least I can speak it for what we saw in Nigeria, that what the COVID pandemic forced us to do was think quickly and act quickly to now pivot the program to go after people. Because as we went after people and sensitized them to HIV and offered treatment out in the community, we then were able to identify cases in the earlier phase of their infection. So I just was realizing that fact and kind of the opportunity that COVID brought when we think about it that way. So what I would just say is I think that there's a phase where there's a lot of people who need treatment and take advantage of the facility. But I think most programs will reach a stage when even those numbers will reduce significantly and will require a pivoting so that we then, are able to find people in the community who are healthy and early in the stage of their infection. Now, once they are with us and at the facility treatment program, in a way, had to adapt to intentionally incorporate advanced HIV disease screening at that early phase. This is something that may not necessarily be necessary when we find them healthy in the community, but decidedly the facility program had to incorporate that advanced HIV disease screening so that we could identify and treat conditions that would preclude an individual to, early ART, to immediate ART because of IRIS, et cetera, et cetera. So I wanted to just provide that perspective.
Thank you very much, Mary. There's another question here, but I think it's related to this last question. I think we can just say that it was answered during the presentation. The question says, how do you ensure that people living in very remote and precarious areas have access to treatment? It takes the example of someone who can only go to the city once a year. But I know that a lot of, if not all of these presentations, mentioned this differentiated service delivery model that ensures that people in these more rural areas don't have to come to the health facilities that very frequently. I don't know if somebody wants to comment more on that, because there are a few more questions I'd like us to take in the next 7 minutes. But I thought every speaker more or less mentioned differentiated service delivery. Stephen, you want to take a go?
Yes, we use drones in addition to differentiated service delivery. We use drone technology to send some of these commodities to very far to reach areas. And our drone program is quite extensive now, and we are still scaling up. So that is becoming a game changer. Thank you.
Well, thank you very much. That's very insightful and useful. And one of the things I think we'll gain from these sessions is that a lot of these things that we started to do because of COVID that are adding value to our services should continue as lessons that we have learned that we can integrate into our normal service going forward. There's one more question here that says, and this again is not directed at any speaker, I'd like to know, based on available data. Okay, this is in Nigeria, so this is for Mary. What is the projection for HIV incidence in Nigeria, particularly amongst vulnerable population, with implemented intervention over the years? Shall I take it again? I think this question is asking, based on what we have been doing over the years in implementing HIV services, are we expecting to see a reduced incidence? I'm just imagining what the question is. Are we thinking that we are seeing some reduced incidence in HIV infections in this very vulnerable population? I think that's the way to rephrase that question. And Mary, the question is for Nigeria, so. Yeah, looks like I don't have. I can just say that, from service delivery perspective and from implementation perspective, we are convinced that we're getting a lot of traction and doing good work targeting this key population in Nigeria. There are a lot of programs that they are contributing significantly to the results that we are getting and the progress that Nigeria is making at closing the gap towards epidemic control. But to answer that question definitively, I'm sure that in the next few years, there probably will be another wave of survey that will tell us exactly and accurately where we are. That will be my response to that question as somebody in the field. The other question I have here, which I think will be the last question we'll have time to take, and I think Patrick maybe should be able to help us with this question. He's saying, beyond advocacy, what else can be done to improve domestic funding in the region, as well as a higher level of government commitment for sustainability, especially considering that we are approaching HIV epidemic control and COVID does no longer seem to be a major threat. And this would probably mean that funding may shrink in due course. So Patrick, based on your presentation at the beginning, maybe you can help us with this.
Thank you, Prosper, and thank you to the colleagues for the question. To be very brief, what one has to do is, similarly as we're trying to change the discourse about our region, we need to change in every country the discourse about HIV. In particular with ministries of economics, ministries of finance, the ministries that control the budget and the purse strings, are parliamentarians as well. Investing in health needs to be seen as an investment. The longer and the more we allow people to see it as a cost, the more difficult our work is going to be. Whereas if we can transform, and I think we have now in almost every country, adequate advocacy, adequate details and numbers to transform the discourse into an issue of investment, that already creates a little bit more fiscal space for all of our budget ministries. And again, sometimes we budget and sometimes we don't end up dispersing what's budgeted. So there are still challenges sometimes with liquidity in a number of our countries at the moment, as we know. But the critical element is to ensure that it is a national dialogue and that the importance of making these investments with our national resources is going to be critical. And the more that we can work together, not just as HIV, but as health and as the broader social sector, to demonstrate the long-term benefits to our citizens, to our countries, to our economies, because of these intelligent investments, the better off we will be. I'll stop there. Over.
Thank you very much, Patrick. I think we have time for one more question, and I will throw this open to any of the speakers. And the question is, what has been the experience across countries with COVID vaccine apathy, which may be an understandable response, considering the relatively low threat level of COVID-19 in the region? I will appreciate one or two interventions as we begin to round up. What has been the experience across countries? How are we trying to address the apathy, given the fact that people already think that COVID-19 is not a big threat in our region? What are we doing?
Okay, thank you very much. Sierra Leone is no exception. And so what we did, first of all, from our community level, was to help give more information to people living with HIV and members of key population so that they can understand the importance and the benefits of getting vaccinated. And once we were able to do that, the leadership serve as role models. We went in, we had ourselves vaccinated, and then used ourselves to actually encourage the community. So we also engaged the vaccination centers so that they were able to come to our specific locations where we mobilize our community members so that they can get vaccinated. Nationally, it is still there is still apathy, but then there has been lots of sensitization, encouragement for people to get vaccinated. So institutions can mobilize their members and then reach out to the COVID vaccination centers, and then they can come to the respective institutions to get vaccinated. So those were some of the innovations that were introduced to help create demand and also have people vaccinated in Sierra Leone. Thank you.
Thank you very much, Idris. And I think at this stage, we will begin to round up. Let me first of all appreciate all our speakers for their immense contribution and participation in this session, especially during this very special and busy time of the year. Just a few takeaways from what we have said. There's no way we can recount everything. I'm sure there'll be a way of sharing some of these discussions, and a lot of the issues were across speakers. But the first thing I wanted to just bring out from Patrick's lecture is the increased need for advocacy for domestic funding. Whatever it is, our ownership must be politically demonstrated that we are committed to continuing from where funding has helped us. That's number one. Number two, which also cuts across what Mary also said, is the need for strengthening the centralized national information system to enable us to take decisions at very, very low levels. When we use the top-bottom approach to do this work, we'll always run into trouble. And I think the example that Mary gave us of what happened in Nigeria, that we find that the comprehensive response that made it possible for Nigeria to achieve in 18 months the kind of number they did not achieve in maybe 12 years or something like that, shows that these things are doable even in circumstances, particularly during COVID. So I think that's something to take home, that this was a catalyst that brought things to bear. And Stephen gave us a lot of opportunities that were created during this COVID. And my hope is that we will continue to rest on these opportunities, even beyond COVID, the extra funding, the innovations, the virtual solutions, and the technologies that were deployed. And Julius mentioned the very important issue that the disruptions in the supply chain during the pandemic was an issue that should affect the way we plan going forward. Maybe like our planning should take into consideration that some of these things that will challenge our very fragile health systems should be planned for before they become important issues. And I like from Idrissa that the experiences from past pandemics were put back to play in making sure that we're able to begin to confront COVID when it came. And so on behalf of APIN Public Health Initiative, we would like also to thank all the participants. I hope that this session had been helpful and interesting to you. We hope that the information shared and discussed during this session will help you reflect on a personal and professional level on the lessons learned during the COVID pandemic for the HIV response. We would also like to thank all the participants. I see quite a number. The number has been very, very encouraging. And those who asked questions, we couldn't take all of your questions because of time. And we also encourage you to share the recordings with your colleagues who were not able to participate with us live today. These will be available soon on the IAS Educational Fund virtual platform free of charge. And they can join the platform anytime to watch the replays, which will be available next week. We hope to see you in the next session in the afternoon for the second session of this symposium, which will start at 3 p.m. Nigerian time. That next session will focus on innovations in HIV testing and diagnostics, the path forward for scaling up. Please connect using the link for session 2 from the homepage of the virtual platform, just as you have connected for this session, or by clicking the link which will be available on this page after this session ends. We'll see you later. Please also remember to participate in the evaluation survey at the end of this meeting for the overall symposium. All participants will receive an email on Friday requesting that you fill in a survey to evaluate this symposium. We will greatly appreciate your feedback, which will help us continually improve our symposiums in the future. And you can also write to us, write to the IAS Educational Fund team anytime at iasedu@iassociety.org. Once again, on behalf of all of the organizers and the planners, I just wish to thank all of you for having spent the last 1.5 hours with us. Again, all the speakers particularly, and have a great mini break until the next session. Thank you very much and God bless. Thank you.